All right, so today we're going to be looking at the axial skeleton, and then moving ahead after the axial, we'll move into the appendicular skeleton. So let's start with what we see here on this slide is the axial skeleton. All right, so what does that made up of? We have the skull, we have the spine, we have the skull, we have the spine, we have the sacrum and coccyx, we have the sternum, and we have the ribs. So pretty much everything in the center is the axial skeleton. And then we will add another dimension to that in the upcoming weeks to cover the upper extremity and the lower extremity. The upper and lower extremity are part of the appendicular skeleton. So there's lots to learn. There's lots of nooks and crannies here of the skull. There's a lot to discuss here with the ribs. When we look at the spine, generally speaking, there's a cervical region, a thoracic region, and a lumbar region. And altogether, there are 24 freely movable vertebrae, and we break them up into 7 cervicals, 12 thoracics, and 5 lumbar. Remember, you eat at 7 a.m., 12 noon, and 5 p.m. 7, 12, 5. The cervical curve, from a lateral perspective, here on the left it's anterior, on the right it's posterior, but if we would rotate it sideways from the lateral perspective or the sagittal view, the cervical and the lumbar curve are called lordotic or lordosis, and then the thoracic and the sacral curve are kyphotic or kyphosis. Those are natural, those are normal curvatures, nothing abnormal about them. So the cervical and the lumbar curve are lordotic, thoracic and sacrum are kyphotic. When you have a curvature like we kind of see here off to the right, where this is called a scoliosis, where it looks like there's a little bit of a curvature or an arc here. That's a scoliosis. Those are abnormal. I also want you to notice in this picture how there are 12 pairs of ribs, and the ribs all articulate with the 12 thoracic vertebrae. So 12 ribs, 12 ribs on each side, or I should say 12 pairs, so 24 ribs, but there are 12 thoracic vertebrae, T1 through T12. So the T1 vertebrae has the first rib, and the T12 vertebrae has the 12th rib. Most ribs have cartilage, as you can see off to the left. This is called costal cartilage, and you can see that the cartilage does attach to the sternum. And the sternum has 3 main parts to it. It has a manubrium up here, a body of the sternum here, and then a xiphoid process. Xiphoid is spelt with an X, although it sounds like a Z. Xiphoid process is the spear, or like the tip of the sternum. So you have the manubrium, the body of the sternum, and the xiphoid process of the sternum. This is all cartilage. And we will learn the ribs as true ribs, false ribs, and floaters. True ribs are the ribs that have true cartilage, their own separate and distinct, like this has its own cartilage, this has its own cartilage. You can see they have their own independent cartilages. Those are true. False would be when they're shared, where they don't have their own independent, but there's shared cartilage. And then there's floaters. The 11th and 12th rib do not have any cartilage at all. They just float. They do attach to the spine, as you can see down here at the bottom, on the left here and over here, but there's no cartilage there. So the 11th and 12th are called floating ribs. All right, so to review, 7 cervicals, 12 thoracic, 5 lumbar. Then you have sacrum and coccyx. The sacrum has about 5 fused segments to it, and the coccyx has about 3 to 5 fused segments to it. We'll go through some of the other landmarks that you need to know of the vertebrae and of the sacrum as well. These holes that we see down here in the sacrum, whenever you see a hole, that's called a foramen. Okay, a hole is a foramen. So these are called sacral foramina or sacral foramen. And what goes through holes? It's going to be nerves. Nerves go through them. Every time you see a hole, even on the skull, there's going to be nerves that travel through there. Okay, so when we look at the skull, this view is the posterior view of the skull. The back of the skull is called the occiput or occipital bone. Then there's this suture called the sagittal suture. You guys remember the sagittal plane from the first exam. So this is the sagittal suture, which is nothing other than the union of when these two parietal bones come together. That point of attachment, that union, is called the sagittal suture. So you have paired parietal bones. You have a right and a left parietal bone. Then we have another suture here that's called the lambdoidal suture. Lambda, 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 the Greek letter lambda. So this is another suture that creates a union between the occiput and the two parietal bones. We could see a little bit of a squamous suture, and you know that word squamous from squamous cells from exam 1. Can't see it too well because we would have to take the skull and rotate it sideways. So if you can take the skull from anterior or posterior and move it to the side view, we'd be able to see the squamous suture near the temporal bone. Okay, so occiput, two parietal bones. We could see a little bit of the temporal bone. Off the temporal bone down here at the bottom is a mastoid process, and then more medial to it, a pointy process called a styloid. If you wanted to feel that self on yourself, you could. You'd go to your earlobe, you feel the bump behind your ear, that round, prominent, bony process is called the mastoid process. And if you go deeper to that, you really have to push your finger in. I don't advise pushing too hard, but when you push in deeper, that's where you get to the styloid process. So there's the mastoid process and styloid. Mastoid is larger and knobbier. The styloid is much, much thinner and slender. The significance of the mastoid process is important because it will tie in to information we will learn in exam 3, which is muscles, right? Because muscles attach to bones. We have to learn bones first. And we're learning all these little bony landmarks because many of them have significance because muscles are going to attach there. One of them that's of importance is the mastoid process. There is a muscle called the sternocleidomastoid. We call it the SCM, sternocleidomastoid. Sterno for sternum, cleido for clavicle, and then mastoid for mastoid process. The name tells you the different origins and insertions of that muscle. Okay, behind the occipital bone, there is the EOP. EOP stands for external occipital protuberance. And if you put your hand behind your head, you're all going to feel a little bump back there in the center back. That's the EOP, the external occipital protuberance. Bird's eye view, looking down. So this is a superior view. Here's the nose. So if this is the front and the nasal bone, back here is the occipital bone or the occiput. Here are your two paired parietal bones. Here's the right and here's the left. Here's your sagittal suture. Here's your lambdoidal suture. And then we have the coronal running across. The coronal would be analogous to the lambdoidal, right? Because the lambdoidal connects the occiput to the two parietals. The coronal connects the frontal bone to the two parietal bones. And again, bird's eye view, looking down, you could see the top of the cheekbone, right? This is the zygomatic bone right here. That's the upper cheekbone. Some have more pronounced cheekbones, some do not. So here's the blue, right? The aqua color is the zygomatic bone. And posterior to it is the temporal bone. Now we can take the head, rotate it to the side, and this gives us that nice view here where you could see the frontal bone, parietal bone, occipital bone, and temporal bone. I like the picture because it has all the different colors isolating the major bones. Frontal bone is in front, occipital bone is the back. Parietal bone is here, temporal bone near the ear. These are important because when we do the brain, which is for the final exam, the brain has a frontal lobe of the brain, a parietal lobe of the brain, a temporal lobe of the brain, and an occipital lobe of the brain. So again, the bones are protecting that major organ and specific regions of it. This area, the purple region just in front of the temporal bone, is the sphenoid bone. The sphenoid is really important. You have to be able to identify it, not just from this view, but when we cut the skull and we take the cap off and we remove the brain and we look into the cavity of the skull from a bird's eye view looking down in, again, we can see the sphenoid, and the sphenoid bone looks like a bat or a butterfly, right, with its big wings. So we will cover the greater wing and the lesser wing of the sphenoid from a different view, but you can see the sides of it here. That's called the sphenoid bone. Here is the zygomatic bone. That's kind of like the cheekbone. This zygomatic arch is made up of two processes, right? If we look at the entire thing is the zygomatic arch along here. This is the zygomatic bone closer to the maxilla, to the front. But when you get to the side, you see there's a temporal process of the zygomatic bone, and then there's a zygomatic process of the temporal bone. They kind of get flip-flopped there. Together, the temporal process here, temporal process of the zygomatic bone, and the zygomatic process of the temporal bone, together, this is the zygomatic arch. Zygomatic bone, more anterior to it. The lower jaw is called a mandible, and the mandible has a few moving parts to it too. There is the angle of the mandible, which is here. This part is called the ramus. The ramus. There is a mental protuberance, and there's a hole here called the mental foramen. Here is the TMJ. So what is TMJ? TMJ is the temporal mandibular joint. So this joint is the temporal mandibular joint. This part of the mandible is called the coronoid process. Coronoid, not coracoid. It's called the coronoid process. This is called the mandibular process. Right there, mandibular process. This hole on the side of the ear is where sound waves come in. So that is called the external acoustic is sound, external acoustic canal. So this is where the sound waves penetrate. So now behind it on the temporal bone, that's your mastoid process. And as you move medially in, that's your styloid process. When we look at the eye from this angle, we can see a few different colors in here. If we start in the center, that's the nasal bone. As we move a little bit more, let's say lateral to it, here's the ethmoid. Let's see if I can find it here. Green here, sorry, that's ethmoid. And then we have our lacrimal. So you have your lacrimal, your ethmoid, and then your sphenoid. Lacrimal, ethmoid, and then sphenoid. LES, less. Lacrimal, ethmoid, and sphenoid. One right in the center, nasal bone. Lacrimal has the lacrimal duct. That's where your tears will roll in, right? So you have your lacrimal gland, you have your lacrimal gland that's always superior and lateral in both eyes, and then your tears roll down inferior and medially into the punctum of the eye, and then it drains right here into the lacrimal duct, into inside the nose. And when your tears roll to the inside of the nose, that's when you get that drippy nose. The tears are pretty dirty, they're filthy. And that creates a histamine reaction inside the nose, where we will see that there are turbinates that swell, or concha or turbinates that swell inside the nose in response to histamine reaction. Okay, above the eye orbit is another hole, and below the eye orbit is a hole. Remember, holes are called foramen. So above that is the supra is above, below it, infra, meaning below. So there's a supraorbital foramen, and then there's an infraorbital foramen. And again, foramen are holes where nerves are going to travel through. When we look at it from the front, we just mentioned before the supraorbital foramen, that's here. And then below the orbit of the eye is the infraorbital foramen. Now, when we look head on, here's our nasal bone. When we look inside the nose, we see this septum, this nasal septum, but the septum is made up of two parts. There's the lower portion called the vomer, and then as we move higher up, it's called the perpendicular plate of the ethmoid. Perpendicular plate of the ethmoid. And this perpendicular plate is going to penetrate up, and there's going to be an extension right around here, but you can't see it in this view unless we cut the top of the cap of the skull off and we look down in, we'd see the extension of the perpendicular plate of the ethmoid come up, and it becomes a structure called a crista galli, the crista galli, which we'll show you shortly. So that's the perpendicular plate. When you hear of people having a deviated septum, there is the vomer, which is the beginning portion of it, and then there's the perpendicular plate. Now, before, you heard me mention that in the lacrimal bone over here, tears are going to roll down and in, and they find a way into the nasal cavity. And these nasal concha, this is the inferior nasal concha, and this is the middle nasal concha. These are going to swell up. They respond to histamine. The other name for concha are called turbinates, and in the word turbinate is the word turbine. A turbine is like a spiral. So when you breathe air in, if we go out on a very cold day and you breathe in that cold air, it's going to spin and centrifuge the air to moisten it, to warm it up. And it's going to allow any debris or dust particles to stick to the mucous membranes of the nose instead of breathing in that debris to the lower part of the lungs where the alveoli are. We don't want that to happen. So again, here is the nasal bone, nasal septum, vomer, perpendicular plate, inferior nasal concha, and middle nasal concha. There is a superior, it's higher up, we just can't see it because the nasal bone is blocking it. But if we cut the skull in half and we looked at it from a sagittal view, you'd be able to see all three turbinates. Okay, so if we move lateral to the nasal bone, we have the lacrimal bone, then we have the ethmoid bone, and then we have the purple sphenoid bone. Remember, less, L-E-S. lacrimal, ethmoid, sphenoid. The sphenoid makes up the larger portion. So this purple for the sphenoid is the same purple that we see here on the side that was just anterior to the temporal bone. So this is sphenoid, and then it comes in here. All this purple is sphenoid. And we see that there is a elongated opening here. It's not a foramen like this. This is called a fissure. There is a superior orbital fissure, and there is also an inferior orbital fissure. And then there's another hole here called the optic canal. You're going to have nerves and vessels that penetrate through the superior orbital fissure, inferior orbital fissure, and the optic canal. There's going to be cranial nerves that travel through. And we have 12 pairs of cranial nerves. You heard me say 3 because when I was looking at this skull, I was looking at the superior orbital foramen, the inferior orbital foramen, and the mental foramen. Those 3 holes is where one cranial nerve that has 3 divisions travels through. And it's called cranial nerve 5, which is called the trigeminal nerve. And this is when you go to the dentist, they typically hit that trigeminal nerve with lidocaine or novocaine, and then half your face goes numb, right? If they're working on your upper jaw, then they want to try and get this numb. If they're working on the lower jaw, they'll try and get that one numb. But usually they hit it in the point where half your face goes numb, your eye, your upper cheek, even half of your tongue, because that's controlled by the trigeminal nerve as well. So trigeminal, 3, there's an ophthalmic branch, a maxillary branch, and a mandibular branch. This is the ophthalmic branch, this is the maxillary branch, and this is the mandibular branch. Okay, a little bit of practical understanding to these holes. Okay. All right, let's see what else do we have here. Here again is your cheekbone, so that's the zygomatic bone. Here is the maxilla, that's your upper jaw. Down below, this is your mental process right here. This is your mental foramen here. Now we take the skull and we look at it upside down. There's lots of nooks and crannies here to look at. So here is the maxillary bone. This is the maxilla, that is the upper jaw still. Here is the palatine, right, like hard palate, palatine. When we look at the purple section here, now remember the purple, that is the sphenoid bone, right? You can see it here labeled on the left. Sphenoid is the purple. So this right here is an extension of the sphenoid, and it's called the pterygoid processes. And there's a medial pterygoid process and a lateral pterygoid process. What's the significance of the medial and the lateral pterygoid? The P is silent in pterygoid. Significance of it is there are 4 muscles of mastication. Mastication means to chew. You're chewing muscles. And I abbreviate them as time, T-I-M-E. The T is for temporalis, right? If you put your hand near your temporal bone and you clench your teeth, you can feel the contraction of the temporalis. That's the T. I'm going to skip the I for a second in time, and I want to go to M. If you put your hands near the angle of your mandible and you clench your teeth again, you can feel contraction at your lower jaw. That's the M for masseter muscle. The I and the E stand for the pterygoids. The I for internal pterygoid, the E for external pterygoid. You heard me use the word before, medial pterygoid and lateral pterygoid. The other name for medial is internal, and the other name for lateral is external. So that's the I and the E in the word time. Temporalis, internal pterygoid, masseter, and external pterygoid. So these pterygoid processes are important It's where two of your chewing muscles attach, where they originate. And they're going to finally attach, their insertion will be to the mandible. So it's going from the sphenoid to the mandible to turn your jaw, to deviate it side to side, right? When you chew, you just don't chew up and down. Think about a person chewing a bubble gum. The jaw goes side to side as well. So it's the pterygoids that are responsible for that lateral deviation of the jaw. All right, what else do we have here? We see we got some other holes here. There is this large hole at the bottom called the Foramen Magnum or Magnum Foramen. This is where your brain descends right through this canal called the Foramen Magnum. And the part of the brain that descends through here is called the medulla oblongata. The medulla oblongata. It descends inferiorly through the magnum foramen or foramen magnum. The other holes that we have here, we have this hole here called the carotid canal. That's the carotid canal. And the one just adjacent to it is the jugular foramen. Jugular foramen. There's another hole that should be here and here called the hypoglossal canal. Hypoglossal canal for the hypoglossal nerve, which is cranial nerve 12. It's a little hole here and a little hole would be right here, hypoglossal canal. Maybe we'll get to another illustration that has it. Here is another hole called a foramen ovale. And if we get another view where we can look at the skull from the inside, we'll be able to see another perspective of looking at the foramen ovale and the foramen rotundum and the foramen spinosum, which are three other foramens. All right, so we have the foramen ovale here, we have a carotid canal, jugular foramen, magnum foramen, and then here's the hole in the ear, the external acoustic canal. Now, if there's an external acoustic canal, there's going to be an internal acoustic canal, and we can see that when we look at the skull on the inside. So let's take a look. Okay, looking straight down here, if we look at the bottom, here's the front of the skull, here's the back, there's the magnum foramen, so the brain goes through here. Remember the sphenoid bone, the purple? Look at that, looks like a bat, doesn't it? Looks like the wings of the bat. And then remember I talked about the nasal septum, how it started as the vomer, and then the perpendicular plate, and then the perpendicular plate comes right through the top as the crista galli. That's like the tip of the rooster on the top of its head that kind of hangs on the top there, like the roosters. That's called the crista galli. The bone itself is part of the ethmoid, but there's lots of perforated holes. You can see it looks like someone took a pin and kept punching holes in the ethmoid. That's called a cribiform plate. And the significance of the cribiform plate is that there is a cranial nerve that goes right through that. And that's called cranial nerve number 1, which is the olfactory nerve. So there are 12 cranial nerves. They're named in order of them being created embryologically. So cranial nerve 1 is the first cranial nerve developed. Cranial nerve 12 would be the last one that develops. So cranial nerve 1 deals with the sense of smell. This is where, when you drink something cold, like a frappuccino or ices or ice cream, and you get that frozen brain syndrome, where it stimulates the olfactory nerve that permeates right through the center. And that's the olfactory nerve involved with that frozen brain syndrome. Here is the sphenoid. I'll show you the two different wings of the sphenoid, the lesser wing and greater wing. But there are some holes that we can see here. Here is the foramen rotundum. There's going to be two others that make a diagonal. I'm quite not sure why they're not showing it, but there's a foramen rotundum, a foramen ovale, and a foramen spinosum. There's going to be three that make a diagonal. Here's the spinosum. There it is. So there's the foramen rotundum. There's going to be another one called a foramen ovale, which is right here. And then the last one is the foramen spinosum, which is this hole here. So it does make a diagonal, these three, 1, 2, 3. It's a little bit easier to see it on the left-hand side. Foramen rotundum, foramen ovale, foramen spinosum, ROS, Ross. Foramen rotundum, ovale, spinosum. Again, foramen means hole. Purple is the sphenoid. So rotundum, ovale, and spinosum are all in the sphenoid bone. Then we have this depression right here. The depression is called the hypophyseal fossa. Hypophyseal fossa. Sometimes they call it the sella turcica. So sella turcica means Turkish saddle, but it is a fossa, which is a smooth depression. And the pituitary gland sits in the hypophyseal fossa. So the reason why it's called hypophyseal is because the pituitary, when you learn about it, when we cover endocrinology and anatomy and physiology too, the pituitary has an anterior and a posterior division. And the anterior division of the pituitary is called the adenohypophysis. The posterior pituitary is called the neurohypophysis. So there's the word hypophysis, adenohypophysis, neurohypophysis, hypophyseal fossa. Okay. The red is the temporal bone. This is the frontal bone. So you got frontal, sphenoid, temporal, occipital bone in the back. Right here is another hole. Remember from the outside, there was the external auditory meatus. Well, from the inside, even if you look at the top half, there's the internal acoustic canal. So there's an external acoustic meatus or an external acoustic canal, and then there's an internal, which we can see right here. Okay, here's the hypoglossal canal. Remember I said before where there should be a little hole here and here, and this one is showing it. So the hypoglossal canal is just on the inner brim of the foramen magnum. You can see it also from the underneath if you looked inward. So there's the hypoglossal canal. That's for the 12th cranial nerve. When we look from the sagittal view, there's also some sinuses that you'd have to understand are there, right? And the sinuses help us produce speech. They help us with our tone and our sound. So here, this chamber in the front near the frontal bone, that's the frontal sinus. Then there is a sphenoid sinus right here. And there is a maxillary sinus as well. But to see the maxillary sinus, we have to be looking at the skull from the front view. And we have to kind of take off a few layers through the coronal plane to be able to see the maxillary sinus. Here from the side view, that is again the hypophyseal fossa of the sella turcica. So this is the hypophyseal fossa of the sella turcica right here. And again, that's in the sphenoid bone. And what sits in here? The pituitary. And that's why when people get these pituitary tumors and the pituitary gland enlarges, it starts to impede or encroach on the nerves that go right through the optic canal or the optic foramen. And people can start to get these visual disturbances, right? So pituitary tumors can push on the optic nerve, creating different types of blindness. Blindness where the person goes completely blind in an eye. They go blind on the left side of both eyes, the right side of both eyes. They go blind on the outside of both eyes or the inside of both eyes. There's a wide variety of blindnesses that show up. Okay, very nice. I like this picture here because it shows the sphenoid very clearly, the purple. And now we could see the foramen rotundum, foramen ovale, and the foramen spinosum, the three, ROS. They make a nice diagonal. It shows the hypophyseal fossa of the sella turcica. We can see the crista galli. We can see the cribriform plate, which are all the perforated holes where the olfactory nerve travels through. We can see the magnum foramen with the hole here and here. That's the hypoglossal canal. Here is the internal acoustic canal. And right here, this elevated portion is called the Petrous Ridge, of the temporal bone. And what is housed within this, what's under here, is the center that controls your balance. It's the vestibule or the vestibular canals of the ear. So that when you move your head forward and backward or tilt it left or right or rotate it, there's liquid that goes through these canals, the vestibular canals. There's an anterior canal, a posterior canal, and a horizontal canal. And it's that anatomy that's inside there that is also sending out output to your spinal muscles to keep your balance. So if you get too much output from one ear and not the other, you're going to get more increased tone of musculature on one side and it pulls the spine. So you get a scoliosis. If you get more output from the other ear, you get more output to the muscles on the other side of the spine and it pulls in that direction. Again, scoliosis. A lot of these happen from birth. When babies are being born, they can put a forceps around the temporal bone and they squeeze and they pull the baby out. That can distort the cranial bones and can really affect the neurological tissue that is located in the petrous portion of the temporal bone. All right. It's also the area that's involved with vertigo. When people turn their head to the right or they go down and they come up and they feel everything spinning, it typically involves the vestibular canals. It's something that's very treatable. I treat, I don't know, maybe a dozen patients with vertigo a year, and it's fixable in somewhere between 5 and 10 minutes without drugs, without motion sickness medication. It's a mechanical problem for the most part. If and only if it's positional, meaning they move their head and it gets worse. Some forms of vertigo are created by medications, which are not fixable. So we really have to diagnose it and figure it out. Okay, so here is the sphenoid, the purple, but here's what it looks like when we take it out, right? It looks like the wings and the wings of a bat. And again, here's the pterygoid processes that I showed you before, the medial and lateral pterygoid processes for the pterygoid muscles. Here is the lesser wing, and here is the greater wing, right? So there's a lesser wing of the sphenoid and a greater wing of the sphenoid. We could see it here again. Here is the lesser wing, and the larger one, obviously, is the greater wing. Here is the sella turcica, right, or the hypophyseal fossa of the sella turcica. And then you can see the foramen rotundum. You could see the foramen ovale. You could see the foramen spinosum. Those three foramen are located in and on the greater wing of the sphenoid. Here is the optic canal. So through the optic canal are going to be the optic nerves that travel through there. Okay, there's just another close-up. There's the sphenoidal sinus. Even the sphenoid bone has a sinus. There's the superior orbital fissure, right? That was the part of the back of the eye. And then there was an inferior orbital fissure as well. Okay, this is part of the nasal bone. If you look up here, the green structure. So remember the perpendicular plate, part of the nasal septum. As it comes up, it breaks through the top near the cribriform plate, and that's called the crista galli. All right, that is the crista galli. And all those little holes that we see on the cribriform plate, those are called the olfactory foramina, little holes where the olfactory bulbs and nerves penetrate through. So again, here is the vomer. Here is the perpendicular plate. And then right through there would be the crista galli, which would come up through here. Again, here's the perpendicular plate to the crista galli. Here's the eye orbit. Here you can see the superior orbital fissure, here and here. And a little bit down, you could sneak a peek at the inferior orbital fissure. There's the supraorbital foramen, infraorbital foramen, maxilla. Here is the temporal process of the zygomatic bone. There's your mastoid process. Here's your nasal bone. When we look at the mandible, let's take a look at the mandible. So here is the angle of the mandible. Here is the mandibular process, sometimes called the condylar process. Here is the coronoid process. Here is the mental process or mental protuberance. The whole is the mental foramen. This right here, this is the ramus. That's the ramus. Here's the angle of the mandible. And here's the mandibular notch. Here's the other mandibular notch. So here, the mandibular process or the condylar process, this is going to articulate with the mandibular fossa on the sphenoid, on the temporal bone. And that's what's going to create the temporomandibular joint. This making contact with the skull for the TMJ. Again, here's a little close-up. Here's the mandibular notch. Here's the ramus. Here's the angle of the mandible. There's your mental foramen, the mental process or protuberance. The teeth are sitting in bone called the alveolar process. Here's the coronoid process here and here. And this is where you're going to have a lot of your muscles of mastication are going to attach here. They're going to attach to the coronoid process, especially those pterygoids. And there's another. Now, don't confuse coronoid process. We're going to do a structure next week on the scapula. On the scapula has a coracoid process. And then when we do the forearm, the ulnar bone has another coronoid process. So there's a coracoid and a coronoid. Okay, this is going to be the hyoid bone. The hyoid is in the throat. It's a very, very unique bone. It's the only bone in the body that does not articulate with any other bone. It's the only one that doesn't actually make a joint with anything. Okay, there is a greater horn, a lesser horn, and a body of the hyoid. Okay, and it's just above the thyroid cartilage, just superior to it. There's lots of muscles that are going to attach to it. Okay, when we look at the eye orbit, again, you have your supraorbital foramen. If you don't see a full hole, sometimes they call it a supraorbital notch, right? But the notch is just the foramen that didn't make its full circle. Underneath it, infraorbital foramen. And now let's find less. Let's find LES. So here's the lacrimal bone, the ethmoid bone, and the sphenoid, LES. This is the maxillary bone, right? That's the maxilla making up the upper jaw. And then the purple here, that would be the nasal bone. And inside, we can just see two of the turbinates or two concha, the inferior and the middle turbinate or inferior and middle nasal concha. We can't see the superior. Okay, another close-up view there. Here's your lacrimal, here's your ethmoid, here's the sphenoid bone. Here's the superior orbital fissure, inferior orbital fissure, and your optic canal. The optic canal is where the optic nerve or cranial nerve 2 travels through. That's for vision. There are other cranial nerves that go to the eyes that go through the superior and the inferior orbital fissure, but they're going to be responsible for moving the eye, not so much for vision, but for motor or movement of the eye. There are 6 muscles of the eye that we will learn when we do muscles of the body. Okay, let's move through this. Again, we could see some of the sinuses again. Here's the frontal bone, so here's your frontal sinus. Here is the sphenoid, so there's your sphenoid sinus. When we look here, this is the nasal concha. Here is the inferior nasal concha. Here's the middle nasal concha. And then way up at top is the superior nasal concha, also known as the inferior, middle, or superior turbinate. This is where you breathe in air and it comes in, it's going to spin it and centrifuge it. But these can swell. The membranes on top of this can actually swell up, giving you that nasal sound. Okay. All right, so when you're born, you can see that these sutures, there's quite a gap between the bones, and these sutures do kind of close off, and the space between them gets a little bit more minimal. But this is why you can feel the soft spot on the top of a baby's head, and you can actually feel the pulsing of blood. You can feel the pulsing of cerebral spinal fluid through there. These joints, as you get older and older, they get tighter and tighter. We say that they are fused, but they're not. There's actually about 1 millimeter of movement or so between each and every suture of the skull. It allows for a degree of expansion. It also allows the pumping mechanism of cerebral spinal fluid from the brain down to the sacrum. Okay. And it's important that these sutures are not closed, because when you look at the diameter of a baby's head and you look at the diameter of the vaginal canal, the math just doesn't add up, right? How does the size of that head fit through a vaginal canal? But because these bones and these cranial bones overlap and they can fold in on each other, when the baby comes out, it compresses coming through the vaginal canal, and then it opens up, almost like the wings of a butterfly. It allows for that recoiling and pumping mechanism of cerebral spinal fluid. Okay, so let me close this one out. And let's just see if there was anything different that I needed to show you from a different view on this other PowerPoint with the skull. Let's take a look. Okay, so we covered the sagittal suture, the coronal suture, the two parietal bones, the frontal bone, no big deal. This is the back of the skull, so this is the occipital bone, the lambdoidal suture, sagittal suture, two parietal bones. Here's your mastoid process, Okay, we looked at these already. We looked at these. We covered this in good detail. It's just real bone, so it may look a little bit different. There are some variations, but even the vomer, right? So here's the vomer, there's the perpendicular plate. You can see the inferior nasal concha. This, right? This is the supraorbital notch, because it doesn't make a full circle, but here it's the infraorbital foramen. There's your frontal bone, here's your mandible, mental protuberance or mental process, and the two mental foramen. Mastoid process, styloid process, external occipital, EOP, the external acoustic meatus, the external acoustic meatus. Here is your temporal bone, and this suture right here is called a squamous suture. Looks like a squamous cell. Back here is the lambdoidal suture that separates the occiput from the parietal bone. And then here's your frontal bone. We look underneath. Again, here is the hard palate, the palatine process. There's your vomer. And then here are the pterygoid processes of the sphenoid. That's your medial and lateral or external and internal pterygoid process. There's your magnum foramen or foramen magnum, the occipital bone. Here is the mandibular fossa of the temporal bone. The mandibular fossa That's where the condylar process of the mandible is going to fit in to make the TMJ, the temporomandibular joint. Okay. Now we're looking inside the skull. Here's the cribriform plate, all the little perforated holes. That is the crista galli, which is the vomer that extends up to the perpendicular plate that penetrates up through the skull. That is the crista galli. Remember the little rooster flap. And then you have the cranial nerve 1, the olfactory nerve permeating through all of these perforations. Here is the lesser wing of the sphenoid. Here's the other lesser wing. And then this is the greater wing and the greater wing. And remember, in the greater wing is where you're going to have the foramen rotundum, foramen ovale, foramen spinosum, the three. Here, where you have the internal acoustic meatus, this is the Petrous Ridge of the temporal bone. If you take this Petrous Ridge, lift it up and move it away, that's where you're going to see the vestibular apparatus of the ear. All right, and there's your jugular foramen and the magnum foramen, or foramen magnum. There's your mandibular condyle that's going to fit in the mandibular fossa to make the TMJ. Here's the mental process and the mental foramen. The teeth sit in the alveolar process. There's the hyoid bone. There's the greater horn. Here's the lesser horn. And here's the body. When we look at the ribs, remember the sternum is made up of these three parts: the body, the manubrium on top, manubrium, the body, and then the xiphoid process, X-I-P-H-O-I-D. Xiphoid is the spear tip. Between the manubrium and the body, there's this junction between the two. And everyone, you could actually feel it on yourself. If you find the jugular notch or the suprasternal notch, which is that depression up here at the base of your throat, and then you move down about 3 to 4 finger breaths, you're going to feel a line or a bump or a ridge. And that line, bump, or ridge is this right here called the sternal angle, or the angle of Louis. And the sternal angle is always, always, always at the level of the second rib. Now, why is that important to be able to feel that and palpate that, to know that that's the second rib? Because if you ever go to the doctor, you have a nurse that has the stethoscope and they want to listen to your breathing sounds or to your heart sounds. When you learn the art of doing a physical examination on a patient, you have to know where the ribs are and where the spaces are. So, for example, this is the second rib, but below it is the second intercostal space. Then you have the third rib, third intercostal space, fourth rib, fourth intercostal space, fifth rib, fifth intercostal space. So they number them on this side. First rib, first intercostal space. Second rib, second intercostal space. You never want to put the diaphragm or the bell of a stethoscope on the bone. You're not going to hear anything. You always want to put it on the spaces so you can hear the echoes of sounds. You can hear the echoing of valves of the heart closing, and you can hear respiration sounds as well. Okay, so you heard me open up the lecture with the ribs. We said there are true ribs and false ribs. The true ribs have their own cartilages, and those are ribs 1 through 7. The false ribs have shared cartilage, if anything, and those are ribs 8 to 12. But the last 2 ribs, 11 and 12, are floating ribs because they don't have any cartilage at all. So 1 through 7 are true, 8 through 12 are false, and of the 8 through 12, the last 2, 11 and 12, are called floating ribs because they don't have any cartilage. Here it's shared. Here it has their own independent cartilage. So ribs, there's a head of a rib, a neck of a rib, a body of a rib, and they all attach to the vertebrae as well as the sternum, with the exception of ribs 11 and 12. They attach to the vertebrae, but not to the sternum because they don't have any cartilage. So again, there is the jugular notch or the suprasternal notch on top, This is the manubrium. This is the clavicular notch. So the clavicle bone is going to articulate right here, and it's going to form a joint called a sternoclavicular joint. Then we move down. There's your sternal angle, or angle of Louis, which would be at the level of the second rib. Then you have the body of the sternum, and the xiphoid process is the very, very tip. Here is the cervical lordosis, the thoracic kyphosis, the lumbar lordosis, and the sacral curve. So the cervical and lumbar curve, notice they go in the same direction. It's convex in the anterior, concave in the posterior. Convex in the anterior, concave in the posterior. The thoracic and sacral curves, they're concave in the anterior and convex on the posterior. When you have a cervical curve that is decreased or that's more straight, they call it a hypolordosis. Same thing with the lumbar curve. If it's too straight and too little, it's a hypolordosis. But if you have a cervical curve that's too much, it's a hyperlordosis. Whether it's cervical or lumbar, it's still hyper. When you have a thoracic curve that is too much, if you get a hump on the back, that's called a hyperkyphosis. So whether you have curves that are too much or too little over a period of time, it always leads to arthritis of the spine. It will always lead to cervical degeneration. So ensuring that the whole of the ear is in alignment with the shoulders, they always make a straight line. That's really imperative. If you have that anterior head translation where the head comes forward and the shoulders round, there's going to be signs of arthritis or cervical and thoracic degeneration. It's inevitable. You can't avoid it over a period of time. And we're seeing more and more of that because when people are like this, right, I'm going to do it from the side view, where they're like this and they're texting and the head comes forward all day, it does a lot of damage to the cervical spine. I have a lot of young kids in my office that are 10, 11, 12 that have arthritis of the neck because remember, most of them are using iPads since the age of 5. So the time they're 15, that's 10 years of forward head translation with cervical degeneration. We're seeing young kids with numbness and tingling and paresthesia in their fingers due to nerve entrapment in the cervical spine. Okay. So when you look at the spine from the side view, notice it's an arc. It's curved. That's normal. This is not a scoliosis. Not when you look at someone from the side, you want to see those curves. Energy moves in arcs, doesn't it? Energy moves in waves. So you always want to see this wave or this arc to the spine. When you start to lose these natural curves to the spine, you start to affect neurological function. And each vertebrae has nerves that come out of it. Each nerve, so let's say between T7 and T8, there's a hole called the intervertebral foramen. And through the intervertebral foramen is a nerve that travels out. And nerves go to muscles and nerves go to organs. And they send out motor information to make your organs work and to make your muscles work. But they also receive sensory information. So the muscles are going to send feedback. The organs are going to send feedback that have to go back into the spine, up the spinal cord, and up to the brain to send that information there to process. So there's sensory information going up and motor information going out. And excuse me a second. And making sure that you have good spinal structure and function, good spinal alignment is really important for neurological function. The better the structure, the better the function. Now, let's take a look at vertebrae, because you have to be able to recognize vertebrae, different types of vertebrae. Now, this vertebrae and this vertebrae look a little bit different, right? They just look a little bit different. So this vertebrae right here is called the atlas, and atlas is C1, the top bone. The atlas is an atypical vertebrae. It doesn't look like C3, actually C1 and C2, the top two bones are atypical. Not typical, they're atypical. They do not look like any other vertebrae. So C3 all the way down to L5, they all have the same parts. But C1 and C2 look very, very different. So let me show you atlas first. This is the posterior arch. This is the anterior arch. Now, usually on the posterior portion, there's going to be a spinous process. There is no spinous process on the atlas. There's a transverse process, though. There's a transverse process. And in the transverse process, there's a hole called a transverse foramen. Very important because we have an artery that goes up to the brain called the vertebral artery that goes through the transverse foramen of C1 through C6. This is looking at the vertebrae underneath. So we're looking above it, looking up. This is the inferior articulating facet. And on the other side, there would be a superior articulating facet. Okay, so most vertebrae will have a superior and inferior articulating facet. Most vertebrae are going to have transverse processes. None of them have a posterior arch and an anterior arch except for the atlas. Okay, and notice there's no spinous process. When you look at a typical cervical vertebrae, okay, there's a body, a vertebral body. We did not see a vertebral body here. But here on the anterior, this is the posterior part, this is the anterior part. So the anterior has a vertebral body. Here, the anterior part just had an anterior arc or arch. On the posterior side, there's a posterior arch. But here on the posterior side, there's a spinous process. Okay, there is a inferior articular process. This is a superior articulating facet. This is the other superior articulating facet because it tells us here we're looking at it from the superior view. If you're looking at it from underneath, underside, then it would be the inferior articulating facet. So vertebral body, spinous process, transverse process, transverse foramen. Right off of the body is a pedicle. So off of the vertebral body, this is a pedicle and this is a pedicle. Off of the transverse process, this structure here and this structure here, these are called lamina. You ever hear of someone that has a laminectomy? That's when they have their lamina removed. So this lamina and this lamina come together, they fuse and they form a spinous process. Okay, so here is the cervical vertebra from the posterior view. This is just showing a superior articulating facet. This is where another vertebra is going to articulate with this one. And then underneath, there would be an inferior articulating process. So these facets, the facet is like the smooth surface of a diamond. That's a facet. The facets are going to be unions for vertebra to sit above it and for vertebra to sit below it. And here is a spinous process. What's unique about the spinous processes in the cervical region is that they are always bifid. Bifid meaning that there's like a fork in the road and it splits. So you'd see one head is here, the other is here, and then here's a depression. It's called a bifid spinous. Once you see a bifid spinous process, you know it's a cervical vertebrae. It's the only region that has that. Here is a thoracic vertebrae. Looks a little bit thicker, especially the transverse process, and the spinous process is not bifid. The transverse processes are much thicker. Here we're looking at from a superior view. Here's the vertebral body. Off the body are pedicles. This is a superior articulating facet. Here's the other superior articulating facet. And then what forms the spinous would be a lamina and another lamina. The canal, this hole right here, this is your vertebral foramen. The vertebral foramen, that's where your spinal cord is. The vertebral body is where your intervertebral discs sit. So if the disc is here and the disc starts to bulge or herniate and it pushes back here, guess what it's going to put pressure on? It's going to put pressure on the spinal cord. If it pushes back this way, it's going to push on the nerve on this side. If the disc pushes out this way, it pushes on the nerve that comes out from the spinal cord on this side. Here's another view. Now it's a lumbar vertebra, much heavier, much thicker, much larger. Here's the body. Here are the pedicles that come off the vertebral body. Here's your transverse process, another transverse process. Here's the spinous process. It's a superior view. So there's going to be a superior articulating facet. And then on the bottom side, there'll be an inferior articulating facet. You could see the inferior articulating process, but you can't see the facet. But this view, you can see the facet. So here's a lumbar view of vertebra from the side. Here's the vertebral body. Here's the pedicle. Here's the transverse process coming right at you from the side view because we're looking at it from the side. Here's the short, stubby spinous process. And now we can see the inferior articulating process or inferior articulating facet. When you're looking at it from the outside, here's the superior articulating process, but the inside surface has the facet. So it would be the superior articulating facet on the inside. Here's the sacrum. Here are the sacral foramina or foramen or foramen or foramina. Your sacral nerves penetrate through here. Here's the sacral base. This is called the sacral ala on top. And then there is a median sacral crest, which is on you'd see these little bumps here that look like spinous processes, but they're not spinous processes. They're just called the median sacral crest because the sacrum doesn't have spinous processes. And then at the apex, you'd have the coccyx. Okay, let me see if I can find a good picture of that for you. Let me just stop the screen share for a second. And let's see if we can find, let's do sacral landmarks. See if we can find the sacral crest there. There we go. So here's the median sacral crest. When you're looking at the sacrum from the posterior, we can see we have the sacral foramina. These are the holes. There's no spinous processes there. It's just a ridge. That's all it is. Okay. I also want to show you, let me just show you C2 axis. I want to show you a few things here. So when we look at the C2 vertebra, remember C1 and C2, they're atypical. They don't have all the same landmarks. The fact that you see a bifid spinous tells us it's a cervical vertebrae. Now, off of the body is the dens or odontoid process. No vertebrae has that except for C2 or the axis. So let's see if I can show you how the C1 and C2 actually articulate, which is right here. So here's the Atlas, C1. Remember, Atlas is the Greek god that holds up the world. Here's C2. Axis is used for rotation. So Atlas sits right on top of the axis. The dens or the odontoid is going to go right through and articulate here. And that's what allows your head to rotate. It's your Atlas rotating on its axis. Okay, this is what fractured. Oh, sorry. Let me go into my screen share. Let me do my screen share. Thank you. Okay, so here is atlas, here's axis, here's C1, here's C2. Here is, remember, atlas and axis, atypical vertebrae, they do not have the same parts as every other vertebra do. You could see it's got a C2 has a bifid spinous process. C1 doesn't have any spinous process, and it doesn't have a vertebral body. It just has an anterior arch and a posterior arch. Here's your axis, C2. That's your odontoid process or dens that's going to go right through here. So your atlas is going to sit. This inferior articulating process is going to attach to the superior articulating process of the axis. And it's going to allow for your head to rotate left and right. So atlas is rotating on its axis. It is the dens that got fractured in Christopher Reeve, which was Superman, right? He was on his horse. Some of you are probably too young to even to know this, but when I grew up, it was Superman, and his name was Christopher Reeve in the initial Superman movies. And he was in a horseback riding accident where when his horse jumped over one of the railings, his head hit the pole and it snapped his head back and he fractured his axis. And this started to put pressure on his medulla of his spinal cord and created paralysis, couldn't breathe on his own, created heart problems. So they end up calling that a hangman fracture when the dens fractures, because that's what actually kills a person when they hang themselves or they get hung, is a fracture of the dens, and it puts pressure on the medulla. And that's where the cardiac and respiratory center lie. So if the dens or the odontoid fractures and pushes on the medulla, the heart and breathing stop working. That's why it's called a hangman fracture. Again, here's a bird's eye view. Let's take a look from this view. Here's the axis, here's the dens, superior articulating facet. Here's your bifid spinous process. Here's your transverse process. And then here are the transverse foramen. If we look at, let's bring in atlas, C1, and we compare, they both have vertebral foramen. Notice how C2 has a spinous, that's your axis. C1 does not. There's no vertebral body, none. There's just an anterior arch, posterior arch, superior articulating process, transverse foramen. If you look at let's look at a thoracic vertebrae. If you look at a thoracic vertebrae from the superior view, here's your body. That's the vertebral body. These are your pedicles, here and here. That's your superior articulating facet, spinous process, transverse processes. Now you see these here, this little facet on the transverse process and the facet on the vertebral body. Guess what's going to articulate there? The ribs. It's a thoracic vertebrae. The ribs articulate to these facets. Everywhere you see the word facet, another bone is going to join it. Okay, when you look at it from the side view, what's unique about a thoracic vertebrae from the side view is look at the spinous process. It's not short and stubby and go out this way like a lumbar. It's not bifid and split like a cervical. It looks like a nose. It goes down. It angles down. So the spinous processes angle down, and the transverse processes actually angle up like an airplane. Okay, so if you look here, you can see that the spinous processes of the thoracic angle down. Okay, so you should know the difference of the key to differentiating a cervical, thoracic, and lumbar vertebrae. So if you see it on an exam, you can differentiate them. There are some key differences. Okay. I am going to, let's see if there was anything else. I think I'm going to stop the screen share. and stop the recording, and then I'll handle any questions.